the program, you can submit your questions using the chat function, and then questions will be addressed at the end of the program. So without taking any further time, Paul, the stage is yours.
Hey, thank you, Sean. Appreciate it. Do I flip through on the presentation, or
Yep.
how do we do that?
Yeah, you can share your screen.
Okay. Okay, can everybody see the PowerPoint? Yes?
Yep.
Good, okay, great. So the intent today is to share with you some factors that are impacting employer health plans, some of which you may know on a global level. You'll hear some things in the news. Certainly we're all challenged by what we hear about rising healthcare costs, and during a political debate, it certainly has topics that come up about universal health care and what that may mean to our health system and choice, all that fun stuff. But I really want to look at what, specific to an employer, what are some of the dynamics that are contributing to the rising healthcare costs, the rising premiums, for your ability to really do the main thing of any business, is to attract and retain your top people, your top talent. So also want to really impart some thoughts about trying to take a longer term approach to employee benefit, which often doesn't happen in my industry. It seems like that a lot of folks will get what they get from the carriers, and maybe they'll bid the same type of plans, and then they'll put in a little bit more money themselves and a little bit more money from the employees and raise some copays and just deal with it, and then they push it off to the next year. Well, unfortunately, I think that in the new dynamic, or this ongoing dynamic, to be able to attract and retain employees and control some level of spending really requires some different management techniques and approach. So let's see. There we go. So we're going to talk about what's the role in employee benefits in attracting and retaining talent, and then why the traditional approach is really unsustainable from an employer perspective and an employee's perspective as well, in terms of what the costs are. So we really need to take some different approach, or employ some different strategies to be able to continue to provide some valuable benefits. Why is there or if you weren't aware of it, maybe share why there's some significant disparities in costs to U.S. employers, or really private insurance, versus Medicare, Medicaid, or other countries. So want to shed a little light on that, and then share with you some uncommon strategies that I've been fortunate for the last 10 years or so. I've been on the board of the Philadelphia chapter of Certified Employee Benefit Specialists. So I get to learn what some insights are from people, where I don't have to come up with these ideas on my own. I could just take all their great ideas and try and employ them for any of our clients. So we'll share some with you that may fit with your size group, and they may not. So I'll try and shed some light in terms of where some of these techniques or strategies could be employed. So I think everybody recognizes that employee benefits are a key concern to employers. The slide that's up now is from the 2020 MetLife Employee Benefits Trend Survey. They do it annually. And you'll see that it's really a six-way tie in terms of employers' concerns about top challenges that they would have in 2020. This is pre-COVID, so we might answer, there might be a couple of other implications or a few other things that could be going on that could rank in there as well. But essentially, it's either 61 or 60% for driving employee productivity, ensuring compliance with different DOL and HHS and IRS regulations as an employer, securing personal data, so cyber risk, attracting and retaining talent, fostering a culture of teamwork and collaboration, and offering competitive benefit packages. So really you see two of the six being some of the main components that we're talking about today is how do we control our spending so that we can provide enough compensation for folks and not have it all eaten up by the healthcare costs. So again, that's pretty much a six-way tie. From an employee perspective, really from the same survey, 86% of employees view medical and prescription drugs as a must-have. That other 14%, they're either in their 20s and maybe are on their parents' plan, or they've got a spouse that has benefits. Because obviously, if anybody has any assets that they're not worried about, or they'd be worried about going bankrupt if something bad were to happen, you've got to have healthcare. Employees rank the importance of total compensation as follows: one is competitive compensation or salaries, employee recognition, so how are you fostering that culture, and then what is a comprehensive benefit package, certainly healthcare being a key component. Challenge, where as an employer, the costs have already been extremely high, but truly they're unsustainable in terms of the trends on where we're going. So you have to take a long-term approach, not just an isolated one-year approach. If we look back at this slide showing that back in, I'm sorry, slide 5. Yeah, so back in 1999, total cost of healthcare that was contributed to by the employer and the employee, $57.91. Employee paying about 26% of the cost at that time. And then 2019 or 2018, $19,616. So 3.5 times the cost over that period of time, still maintaining about the same contribution level of the employees. But that trend of it continually rising for the employer and for their employees, certainly you can see the premise of the presentation is that it's unsustainable. Something's got to break. At some point you run out of money. This study was done by the Kaiser Foundation. And we'll get to another slide that will show that actually in 2020, that number is over $20,000 per employee in certain surveys. And what's happened during that time to be able to mitigate that number, so what makes it even worse, and sorry to be so gloom and doom, what makes that rise, those numbers even worse, is during that period of time, not only has the employer and the employee contributions gone up, but we've also been increasing the employee out of pocket, either through higher copays, higher deductibles, more coinsurance, shifting of services. So the employee out of pocket has gone up, and this is just one snapshot of a survey between 2013 and 2017, by 12.2%. So typical scenario, and I'll get to this a little bit later on as well, is get a renewal increase, employer tries to, maybe you bid the coverage, you're trying to add a little bit more employer contribution, you ask a little bit more of the employees, and we'll also increase the employee out of pocket. So at some point you're devaluing the benefits that are in place just to try and get through to the next year and fit it within some level of a budget of what you can absorb. The impact of the employees is really dramatic. Got a study here, it's dated, but this one that I've been looking at for a while is by the Brookings Institute and published in the Wall Street Journal, that looks at what has been the change to the employees and shows healthcare rising as a component of disposable income or a component of what the employees are spending by 25%, whereas really all other aspects, whether it's food, housing, transportation, other aspects, clothing, spending's gone down. So the employee is having any disposable income, their money being eaten away by this problem. Prescription drugs are a big component, and really that I think is the, and again, sorry to be gloom and doom, but I think there is hope. Prescription drugs are a real challenge, whereas we've seen total spending on prescription drugs be somewhat mitigated by major shift towards generics and the number of generics that are available in the marketplace, which has drastically reduced costs. But that is countered by a massive increase in the costs of brand name drugs, as well as the influx of certain specialty medications that are really big ticket, high dollar items. So a study that was published in the Journal of American Medicine has shown that between 2012 and 2017, 48 of the 49 most common brand name drugs increased. Not surprising that, hey, costs for things go up, but it's the level of the increase that to me is staggering. 3/4 of those drugs, of the 49 most common drugs, went up by over 50%. Half of them more than doubled. And the average price or the median increase was 76%. So that's staggering over that shorter period of time, the dramatic increase in the costs of brand name drugs. Just mentioned specialty medications, and that is a tidal wave that is already hitting, but it's going to even be more dramatic. 2014, the US spent roughly $374 billion on all prescription drugs. That includes generics, brand names, everything, specialty. In 2020, we're expected to spend as a whole healthcare system, $400 billion just on specialty meds alone. It's daunting in terms of what that does to the ever increasing healthcare costs in general. 2% of the medications right now are specialty meds, but they represent in 2020, the projection that I take from various studies, that it already represents 50% of the cost of RX spend in terms of total, generic, brand name, and specialty. The average cost of the 61 most widely used specialty drugs for various chronic conditions is $78,871 per year. So having employees spend an extra $100 for deductible on prescription drugs, or a $70 copay per month, perhaps, on some of these medications, that is a drop in the ocean, not even just a drop in the bucket in terms of what the total costs are to the employer plan. And again, it's increasing. So there's various articles and things that are out there that you can see that are about, where did our raises go to healthcare, a cancer on the dream, or a cancer on the American dream. One study by the Kaiser Foundation shows that when you combine employee contributions and out-of-pocket costs, so what's coming out of my paycheck and what am I paying through copays, deductibles, and whatnot, employees spent 67% more in 2018 than in 2008. So just in one decade, one 10-year period of time, that's the rate of increase. And certainly inflation and wages haven't gone up by that. So this is eating into wages, it's eating into employees' satisfaction level with their healthcare plan, whether it's coming out of their paycheck or it's coming out of their pocket in copays and deductibles. So another somewhat gloom and doom slide is that there's a major disparity between what we pay in the US for private insurance and commercial insurance versus other countries. They're actually even in total. This slide includes Medicare and Medicaid as well. So per person in the United States, and this is a very recent study, this is 2020, I think it came out in June, by the Peter G. Peterson Foundation, showed that in the US, it's $11,072 per person. That's man, woman, child. Switzerland, $7,700. Average of all developed countries, $5,496. So big challenge in terms of what we as a country can do to be able to afford all this. But really it is more concerning, more concerning in terms of what we as maybe private insurers or private employers have to deal with. Because a component of that number, that 11,000 number, assumes that a certain amount is paid by Medicare and Medicaid, and a certain amount is paid by private insurance. Whether it's employer-based or sole proprietor gets a policy through ABC carrier and pays her out of pocket. Is that there's also a disparity between private insurance and Medicare. Study was done by the Rand Corporation across 25 states and showed that employer plans paid 240% of what Medicare would pay. So let that set in, is that we all know that maybe Medicare is paying less, but how much less? So the burden of all these things is largely put on private insurers to be able to foot the bill for all this. And the trend is getting worse. So Medicare, Medicaid spending relatively flat. You'll see a little blip between 2016 and 2017 for Medicaid. It has to do with a couple different things, but predominantly Medicare patients flat in spending for inpatient hospital. Private insurance spending for inpatient hospital growing. That's the pink line. So big problem, getting worse in terms of a trend, in terms of it being higher than spending in other forms. Here's a stat that was issued by the Pennsylvania Healthcare Cost Containment Council about, looked at the most common procedures, study done or averaging all the data between July of 2017 and June 30th of 2018. Average Pennsylvania charge for a knee replacement, $52,660. Cost to Medicare, $12,234. Now don't take that to heart in terms of what the plans pay, because all plans, this might be what you could be charged if you just walked in off the street and you didn't have health insurance, you were uninsured, that they might put a charge of $52,660 on you. But all plans, PPOs, point of service plans, HMOs, will have discounts in place. But even if that discount with the carrier is 50%, you're still paying twice as much as Medicare. Private payer payment rates, more than twice Medicare for respiratory diagnosis in 2017. Put this in there because it was a study that I looked at a couple of months ago, and it really had concerns over the impact of COVID-19. So for somebody to be on a respiratory problem with a diagnosis code 207 that's on a ventilator for over 96 hours, the charge to private insurance would be $100,461. The charge to Medicare would be $40,000. So to the extent that there's employees on your plan that might be affected by the coronavirus and might have to go on a ventilator, the numbers are big. The numbers are very big. New York Times, just something to throw out there, costs are double or triple. Appendectomy in Great Britain, $3,000, New Zealand, $6,700, United States, $13,000. Something that I wanted to throw out there because it leads to a concept that's towards the end of the presentation of what some strategies are that could be employed to be able to mitigate some of these costs, relates to something called medical tourism. And there was an article in the Kaiser Health News for, hopefully everybody's heard of Ashley Furniture. It's out there. So an employee on their plan, they implemented something called medical tourism, where if you want to have your procedure and you're going to go the traditional route, it's X number of dollars in a deductible and a copay and out of pocket and all this fun stuff. If you go and have the procedure done in some selected space, no cost, will fly you to perhaps some exotic place like Cancun, and you can have the procedure performed. So there are places in the world, in Canada, in Mexico, and in other places where many times they're even staffed by US doctors that are performing the procedure. In this example, the the surgeon that was performing the operation and the knee replacement was from the Mayo Clinic. They were actually paid 3 times what they would have been paid had they done the procedure at their own normal hospital. They got a trip. Employee pays nothing. Dramatic change in what the costs might be for a procedure. $30,000 if that procedure had been done in the United States for everything related to it, just a traditional knee replacement. $12,000 in a facility. It's called the Galedo Hospital. And supposedly it's exotic and wonderful, and they're staffing it with top-notch physicians and facilities. It's not what some would consider a third world country where you're going to a veterinarian in some far-off land to get some service performed to be able to save money. Medical tourism is becoming a more and more prevalent approach to be able to how to control some costs due to the high cost of healthcare in the United States. So RX cost to employer-sponsored plans, something in the Pharmacy Times, where they're unlike really any other service good that may be purchased. There is less transparency for consumers, for an employee or for an employer within their plan about what they're paying for any service, whether it's in hospital or it's prescription drugs or really anything that's out there. There are things that seem on the surface that are mitigating a lot of those costs for prescription drugs, especially, as we will get a discount off of the average wholesale price, and we will get rebates, and all these nice things might happen to try and mitigate the costs, and we might have some of those things be tangible. But there's still a lot of gray within the process on how PBMs, pharmacy benefit managers, are making a tremendous amount of money, record profits, and for reasons that I'd be happy to discuss, they're all tied to healthcare carriers. So all the big names that are out there. So it also happens where if you're an employee and you don't have insurance, the manufacturer may offer coupons or certain discounts so that it may even be free, but the employer plan is charged, and the employer plan could be charged hundreds of thousands of dollars for medication, and even with a discount or a rebate or something like that, it still may be dramatically different than maybe just an employee walking in off the street that needs that medication, says they can't afford it, might be provided to them at little or no cost. There's some pressures. Again, we're close to the time where there's going to be some bright spots, where there's going to be some hope. So some things to consider that are going on where healthcare spending is down right now for a variety of reasons due to COVID-19. Certainly there's a delay in elective surgeries. So that's been postponed. Problem is, if they were needed, they're going to be done at some point in later 2020 or in early 2021. So that's going to put pressure on the healthcare system or on spending. There's certainly been a delay in diagnostic procedures, and early detection of health problems could crop up and put some more pressure on the healthcare system and what spending may be in 2021. Medical providers, because of the lack of elective surgeries, are certainly challenged economically. So they could be trying to find different ways of increasing the revenue that they may be getting as a healthcare system, or what their charges may be, or rethink the level of discounts that they may give to any of the carriers. Testing, somebody's got to pay for testing. Whether the government is helping to subsidize some. A lot of these testings may actually hit the employer plans to the extent that the employees are going out and being tested. Treatment of those afflicted with coronavirus. So just talk about $100,000 if someone was on a ventilator for a certain period of time. If that happens to be some of your employees or their family members, that's certainly a challenge to the plan. When a vaccine becomes available, Maybe think it's coming over from Russia this morning, probably got a couple crate loads of it, but who knows when a vaccine may be available, but who pays? What impact does that have to healthcare plans? Increased mental health costs. It's certainly something that is we've been becoming more aware of that, and there's statistics that are coming out, the challenges that folks might have had already in any mental health conditions can certainly be exacerbated by the challenges we're all facing with being quarantined and life changing. So what has often happened, and I throw up this slide as Groundhog Day, is typically and I'll take some fault as much as I try and refrain from it, is that a common approach would be an employer and working with a broker consultant will get a renewal increase from the carrier. Maybe you bid out the coverages to look at some other carriers, but you just try and deal with it as best you could for the year and the open enrollment period that you've got in front of you. The employer might contribute some more money. The employee might contribute some more money out of their paycheck. Maybe you raise those copays and deductibles. But based upon what I was sharing earlier in the presentation about the trends, and it not getting any better and potentially getting worse, especially as it relates to specialty pharma. I think it really requires taking a more long-term approach. Benefits have been different than what a manufacturer might have in terms of looking at their costs, they're spending for maintaining insurance for property casualty, maybe the safety of their manufacturing plant. That's got to be more the approach that an employer really has to take as we're all trying to maintain valuable benefits that are perceived well by the employees. It really is going to require more constant management, much like you would in trying to promote safety within a manufacturing plant or something like that. So here's some things that are out there. Be happy to talk with anybody individually, or people can go to their current relationship of a broker, consultant, and such. I would challenge, if you haven't heard of these things before, that maybe you might want to consider a change, because many of these things are out there. They're innovative strategies, and many of them can have a very dramatic impact on what your healthcare spending is, so that you're maintaining more money to be able to compensate people. A lot of folks have moved, and this is really down to even smaller groups, smaller employers, down to sometimes even 10 employees have gone self-insured. That's got certain risks to it. It also has certain benefits, rather than paying for, if you've got a plan that's under 100 employees and trying to move away from the platinum, gold, silver, bronze plans that would be the off-the-shelf plans in that type of market space. Moving to a self-insured environment, if your claims are better than average, could certainly be a way of saving dramatic amounts of spending. But self-insuring alone really doesn't control the costs. What it does is really puts the risk on you with protection called stop loss. You can have some protection there, but you need to get at what your spending is if you're going to be able to maintain that being an optimal spend, and reducing the cost while maintaining the highest level of benefits. Concept is out there, has been out there for only 10 years, but it has really only been employed on a very limited basis within all of employer plans, called reference-based pricing. So as I showed before, the dramatic difference between what a hospital or a physician may accept and be paid for Medicare for one procedure. So I've got a Medicare patient. This is the standard protocol. This is the treatment, the exact same procedure, all things being identical, to somebody that's covered on private insurance could be 200%, 240% of that in terms of Pennsylvania, or I'm sorry, being the average 240% higher. Would a hospital, would any kind of healthcare provider accept less? And that is the approach in terms of using various benchmarks. Medicare is one, and certainly one that is commonly used and commonly understood, because it is set for all different types of procedures that are all listed. There's a fee for a procedure. that's in place. So it is very common that there could be negotiations with a provider, particularly a hospital, or other types of diagnostic testing, like getting an MRI or getting lab work done, that can dramatically reduce spending within a plan that could really change the world. So reference-based pricing is out there. It's been out there for over 10 years. One of the things to just consider is you need to really be choosing an appropriate vendor so that the employee is not left on their own to deal with some level of balanced billing. So the charge goes out to the carrier, to the vendor, you try and pay less, and if the bill just hits the employee to pay the difference, that really isn't the path towards maintaining a valuable plan for the employee. It's just a cost shift. So certain vendors take a more active approach in terms of supporting the employee through the process and navigating everything. But reference-based pricing is certainly one. Not employed on a very large scale now, 2 to 5% of employers. Studies are that it's going to grow to 10 to 15% within a year or two, because the differential that private insurance is paying is just, again, unsustainable. Chronic disease support for participants, and this is got a wide variety of different things, and some could even say that it could fold under a larger umbrella called wellness. I like to really focus on it as being disease management. Wellness, I'm a proponent of it. I think you can engage employees, have them thinking about the employees, but a lot of times you wind up handing out water bottles to triathletes, and those aren't your problem. And again, it's good employee engagement. It's always good to have to try and assist people in getting healthy and incent smoking cessation and incent getting biometric screening so that people are getting their blood pressure checked and getting preventive visits so they're identifying problems before they really become exacerbated and become high dollar items. But I'm talking about disease management where you've got a great deal of support for your high dollar people. And it's the cancers and the strokes and it's people with COPD, diabetes, and really being at their side, and hypertension that are prone to strokes or heart attacks, having some engagement to support that person towards mitigating claims, a healthy lifestyle, making sure they're on their medications, getting at the 20% of the people that are causing 80% of your claim costs is the dynamic. And there's a whole host of vendors and there's different approaches and all that stuff, but that's what you want to get at. You want to mitigate the claim costs and make sure that people are having the right care and care that they view as valuable and is not a burden to them that they perceive as big brother, but it's a support mechanism. Pharmacy benefit management, it's always been a big deal, but I think with specialty meds and with the rising costs, I think hopefully I've expressed my feelings on why it's so important. And it's about the lack of transparency that's going on and the contracts that are in place. I'll jump up on if I'm not already on a soapbox, I'll jump up on one a little bit to maybe see how I frame it. Is the top 5 pharmacy benefit managers are really controlling somewhere upwards of 95% of all claims that are being processed paid today within our system. The household names that everybody would know would be Express Scripts, Optum, and Express Scripts is owned by Cigna. Optum is owned by United Healthcare, and CVS is owned, or CVS owns Aetna. My, perhaps jaded, but I view as realistic view on it is that they didn't all get together to lose money. And there could be some great synergies and efficiencies that are created by banding together. But they're all, even before COVID, they are all reporting record profits. The profits in the first quarter, or I guess second quarter, are off the charts, and by no fault of theirs, because of the lack of elective surgeries and people going into the doctors and all that. But a lot of money is being made, and there are vendors, there are approaches that can be taken that bring more transparency to the process in terms of what an employer may be spending on the prescription drugs. Now, this has to really be in a self-insured environment. Again, self-insureds could go down to 10 employees, really start to hit its stride around 100 employees. But there are, you may just have less choices and less levers that you can push and pull to be able to mitigate some of your claim costs when you start getting below 100 employees. But they are out there. High value networks. A lot of those are currently employed. If you're with IBC, the Blues, if you're with Aetna, you're with United Healthcare, you're with Cigna, AmeriHealth, you would commonly see that they've started to employ different tiered networks where you've got a preferred provider organization and it's all these doctors. And that if you go to any of these, your copays are X. If you go to a smaller set of providers, your out-of-pocket is less. So it's driving you to what they would consider high-value providers, so that they may be providers that the carrier has deeper discounts with, or they've identified them as having better outcomes. And that's the ideal situation. You just want to drive people to the optimal setting of care. If you get your MRI in the hospital, it's X. If you get your MRI at a freestanding clinic, which could be a third of the cost, maybe you don't even have a copay, or CAT scans or other blood work. Whatever you may be receiving as a service, if you're going one setting, it's a certain level of out-of-pocket as an employee, and if you go to another setting that maybe provide more value, be more optimal from a cost standpoint, you could have less. I'll often say that I've been saying this for a number of years, is that if you have a preferred provider network and every physician and every hospital is in it, that's not really a preferred provider network. Yes, what it does is it reduces or eliminates noise. So you don't have employees complaining about my doctor's not in the network and now I got to switch and I've got to develop a relationship with somebody else. And that's disruption and it's painful and there's anxiety and all that stuff. But to be able to have something that is really preferred, where you're getting deeper discounts and being able to reduce prices, you're driving people to certain places. And yes, there is a burden of inconvenience that comes with that. So mentioned the example before about medical tourism. Really just a concept that can be employed in many plans. Usually the larger the plan, the more they may employ it and force the issue. But hopefully you saw by the example that you could have a US surgeon perform something at a high quality, safe facility. It's outside of the United States. And maybe it's for something like a knee replacement, a hip replacement, something like that would be a very standard procedure. You can have dramatic savings, even the transportation of the employee, the patient covered. Sometimes they'll even provide some additional incentive, all to be able to reduce the costs to the plan. Telehealth, certainly something that's been discussed a lot in the current state, where people are uncomfortable in going into a doctor's office and maybe contracting the coronavirus. But even in general, it's been around for a while to say it's more convenient for a certain set of services, the earaches, that a child might have, maybe an eye infection, sore throat, certain conditions that someone might have, where the doctor can call in a prescription to the pharmacy, and you never have to go into that waiting room and wait an excessive period of time and maybe contract some other illness. So that's been there. But where I believe the market is going to see it be more prevalent and be more impactful is more primary healthcare and the engagement with somebody that is working with a patient, and it's a much larger list of services. So it's not the urgent care that you might see where you're not going into an emergency room or waiting to go see the pediatrician when you may already know that your kid has got an earache and it's their third one that they've had, but ones that are more involved in the engagement of chronic diseases and disease management. So virtual primary medicine is something that is going to start creeping up more and more in the conversation. Next one is claim audits, and carriers might say that they perform claim audits and they maybe do it over a certain percentage of claims. But if you are self-insured, it would be advisable that you are very comfortable with whoever is managing your claims, processing the claims, that they're doing extensive audits, really on all hospital claims, but perhaps more than that. You would definitely need to do it if you've employed some concept like reference-based pricing, where they're trying to get better deals on any service that's being performed. But when it comes to hospitalization, the Office of the Inspector General did a review of claims over a certain period of time, and it was a random sample, 200 claims out of 224,000 for a certain set of procedures. And they found that 86.5% were incorrect, and they were going to collect and have charged over $1 billion in money that needs to be received back into Medicare based upon upcharges and overbilling. One of the vendors that we work with, and they review every claim, and they said that when it comes to hospitalization claims, 90% of their statistic is that where it warrants their involvement, because if they weren't getting any return on the time they're spending on reviewing and auditing claims, they wouldn't do it. It would just be adding more cost to the system. 90% of claims that they review have errors, and errors to the favor of the payer or the employer plan. So if you're self-insured, claim audits, getting people to the right setting of care, motivating or incenting employees to be able to get care in the most optimal setting, like outpatient and freestanding clinics for MRIs and those kinds of things, all really important. Managing the prescription drug costs, all that is some of the techniques that are out there. And there's many, many more, but in the interest of time, didn't want to keep people all the way going through lunch and maybe even into breakfast tomorrow to discuss all different strategies and techniques that might be out there. So be happy to discuss these things and field any questions, whatever anybody would so desire.
Paul, this is Kevin Kent. I do have a few questions, but I'm gonna hold until we see if we have some from a few others. So please chime in if you do. Well, I'll jump in. This is fascinating. And I'll confess, Paul, that I kind of rely on my CFO to look at these things and kind of just give recommendations. And I've never really taken the time to look at the level of detail that is in a presentation like this. Who is your ideal point of contact for most of your target clients, and what are the hurdles that you have in terms of getting people to pay attention to some of what you offer and what some of your messaging is? Because it's fairly persuasive, but how do you get there?
And it does depend upon the organization, and really the relationship between HR and the CFO would be one way to frame it. Mm-hmm. So ultimately it does come to the CFO and then the management team. But it is the challenge that we have in engaging in the conversation is everyone thinks that their broker's doing a great job. Not everyone, but most folks. And people get phone calls night and day from other vendors, people like me, that say they've got a better mousetrap and they've got different innovative ways of looking at it. And people are just so burdened by that they're not receptive to taking on new calls. So calling HR is a great place to engage in the conversation, but it is sometimes more of a challenge in calling that dynamic. To their defense, only because of the number of calls that keep coming in to them. So if you can get a bit of time, and normally I would need less than the 45 minutes of the presentation to really hit some of the highlights. It is often most beneficial from a time standpoint to convey some of these things with the CFO, and then certainly bring in HR as quickly as possible. Because from an HR perspective, and not to say that everybody doesn't have the same mindset about costs and the value of employees, but when we talk about the ability to attract and retain employees, and if that number just keeps getting eaten up, where we can't pay people a compensation that we view as competitive in the marketplace, that's a very HR feeling conversation, a very analytical conversation from a CFO standpoint. So hope that kind of answered your question. It really is kind of the dynamic between CFO and HR. It's both, but how that works in terms of who to go to first. You've got to engage really on the dollars and cents, and you got to scare people with all these trends, and just have people recognize maybe it's a little offshoot of the dynamic of Groundhog Day that I talked about. But very often it's not much. It's once a year we look at it and we dive in deep and we review all this stuff, and then we're set for a year. And really it's got to be a very different kind of thing, because if you're not looking 3 or 4 years out, those trend lines will eat up your business. Unless you're so successful and you're growing so quickly that maybe not be your top concern. Being able to have more money on the table to attract and retain talent should really be a big concern.
Yeah. Yes, you did answer my question, and I also agree. More money is better. Any other questions?
Yeah, Paul, this is Mike Daly. First of all, I just want to point out that all what you said is geographically and regionally, and also size of your company, okay, dictated. And that is, in our area, you really only have 2 or 3 different options. You probably only have one option if you're a small company below 50 lives, okay? If you're between 50 and 200, you have some other options. And above that, you can kind of rule the roost and try to manipulate all the things that you're talking to. So I just wanted to point out that it's very specific relative to size, and your broker has to have that knowledge, because not all the Aon representatives that want the 1,000 plus live markets have a knowledge if they're serving a 25 life company. That you're going to be better up with that specialty. The other thing is I have to defend the medical device and drug companies, okay? 89% of the drugs in the United States are generic, okay? That Europe and everything else don't have generic drugs, most of them, okay? So we are saving money. Part of that cost is a kind of a manipulation of things, because we have these incredible drugs like Gilead's drug for hepatitis C. We actually cure a disease with that drug. Granted, it's $25,000, $30,000 for a treatment, but the comparator, okay, was an awful quality of life and perpetual treatment. So that $25,000, it goes into, like, all of a sudden the drug costs $25,000 and went from 25,000 to 30. I would argue they should be charging $100,000 for it, because the cost over a lifetime of treating hepatitis C could be, a couple of $1 million. So I'm just trying to put this perspective in place. And of the top 5 money makers, pharmaceutical and biotech and med tech devices don't even make the top 10, okay? In the top 5 are banks, health insurance companies. This is a shout out to you, Rick Freeth. It's real estate leasing companies. We don't even make it, because there's so much risk associated with this that companies go bankrupt. Mallinckrodt's going bankrupt because of the opioid thing. So I'm just saying there's just tremendous risk, and attacking an industry for healthcare when it accounts for 7% of the total healthcare costs seems to be misappropriated. And that's what Congress was doing 9-10 months ago. And now, we've gone from zeros to heroes because we're going to pull the pharmaceutical companies. Unbelievable what's been done in the last 3 months. So I just needed to defend that. And I think you're arguing very strongly. When Medicare can negotiate better prices, single payer, that's where we have to go. And that's what we're comparing ourselves to all of Europe. Those are for the most part, single payer with additional private insurance on top of it, but it counts for probably only 10-15% of their healthcare costs. So, and I don't know about you, but I know a lot of people that complain about IBC or Cigna or United Healthcare. But I have real problems if anybody that's on Medicare complaining about Medicare. It seems like the government does a reasonably good job there. So anyway, that's my shout out is kind of a defense, but also where is the cost going to? And do you see that single payer thing? Controlling drug pricing is not the answer, because then what are you going to do when a kid that has a rare disease, it costs $1 million to treat them? That goes into your pie for statistics. But I mean, what's that kid's life worth versus an 80-year-old? My father-in-law had a hip replacement 10 months before he died of terminal cancer. He was already diagnosed. I don't know. I think that's absurd for a healthcare system.
Yeah, Michael, I appreciate that. And I'm not just saying this because you're on the call, but maybe let me pivot a little bit or maybe see where I think we've got probably maybe a little bit more agreement than maybe, unfortunately, maybe how I express some things, is that I think the manufacturers that are bringing these things to market are, I don't want to say the problem. What I was trying to express is really just the problem that an employer faces in being able to provide attractive benefits to their employees and how to manage costs and some different strategies. But the R&D and all that other stuff, absolutely in agreement. What I see as a concern I've got with the marketplace, where this is maybe different shades, is the healthcare companies and banding together of the healthcare companies, the major ones, with their pharmacy benefit managers. So combining the Aetnas and the CVS, I don't view that as a good thing. One person's opinion, and obviously everybody's entitled to their own. But the control they've got of all that, I don't know that they all joined together to make any less money that was there. And are they an advocate of optimal care, of managing chronic disease within their patient base, as opposed to getting more medication on the streets? I think to your larger point about Medicare for all, and say that certainly could make things easier and cut out spending that is in certain areas. But the challenge, I think, for all of us is going to continue to be, just as citizens or as employers, is can we absorb the $1 million claim? And that's the ethical decision that I certainly don't want to put myself in the position of making for the life-saving medications for that child, and the research and great intentions of all those scientists that are out there developing meds. I think that's the tough one for all of us, is how much can we afford before there's no more money, or what are the impacts on that economically? I just try to express to say that here's how the game is set up now, and there could be some alternatives to try and help the employer in that game with different type of strategies. And a number of them can be done really down to, let's say, 25 employees, but absolutely in agreement that the larger you are, the more you can employ more of the strategies that are on the list of those 2 pages of things, and many more that are out there. So I appreciate that, and certainly wouldn't want to cast a negative light on either manufacturers or people that are delivering devices or medications.
You can cast that on the PBMs if you want, because they add no value and they don't return any money to the patients. So somehow or other, I don't know whether anybody's negotiating that.
Yeah, if there's any PBMs on the call, I will have a little bit tougher time guarding my negative opinions in terms of what their value is to the healthcare system. And we've got some things in place that even on smaller cases that can totally change the dynamics of what the discounts are, what the rebates are, and potentially save 20% on prescription drug spend for everything.
And
Because bringing
I
light
just want to make sure we're, Paul,
Yeah.
I'm sorry, that we're cognizant of time, and I think there's at least one other question out there, I think. So I'm just making a suggestion, maybe we wrap up
Good.
that point. Oh, okay, good. Brendan, did you have a question? I think we're having trouble hearing you.
Sorry. I would just say, regardless of your viewpoints of whose fault it is for the rise in cost, it doesn't really matter to me as a small business owner. I just want to see what my options are of decreasing the cost for myself and potentially for my employees.
Yeah, wish I had the power to change everything, but I'm just trying to help navigate through the game that as it's set up right now.
So, Paul, what is the best way? Just have HR or a CFO or somebody in the organization who makes the decision contact you and your group?
That would be great. Yeah. And you can start out with a quick phone call, something like this, just share some of these insights and see, based upon the size of the group, whether or not that which techniques can be employed.
Thank you.
And Paul, I'll end with this last question, and it kind of ties into Brendan's, but beyond what you just mentioned, what else can those of us on this call do in terms of connecting you, keeping an eye out for the right connections for you and your firm?
You're on mute.
Just got it off. I would say that any group that you know that's got more than 25 employees, and ideally with most of the strategies, if they have more than 100, and the reason 100 is important is that the carriers, if they're not self-insured now, typically if they can get claim data, they can get prescription drug data, and we can actually rerun their prescription drug spend through a couple different vendors that I use that will provide the analytics to say that if you had employed these strategies, it would have saved you X. Here's what the deals and discounts and what the spend would be. We can reanalyze that data. So 100 employees gets you the data, and also for the medical claims, especially for reference-based pricing. If it had been reference-based pricing, could often save 20 to 30%, because instead of being 240% of Medicare, they're typically 120% of Medicare, 120 to 130% of Medicare. So for your surgeries, your inpatient hospital spending, that's where there's a big hit there. Getting the data helps, and often if you're not self-insured already, you're not going to be able to get that from the major carriers. So we can do some things if 25 to 100. We can do more things over 100. If you're over 1,000, we've got some tremendous things that we could do, and potentially not even disrupt a relationship maybe with a main broker consultant. Just add some things. That could cause some friction, but still be happy to do it.
That's pretty helpful to have that breakdown. I want to be cognizant of everybody's time, and we've run slightly over for good reasons, which is some good questions and commentary. Paul, thank you very much, you and U.S. Employee Benefit Services Group for putting this together. It's really one of the more fascinating of these that I've seen. A reminder to everybody.
Hey, Paul, real quick before we go, can I just ask real quick? This isn't so much a question, just this deck that you've shared with us, is that something you're able to share after the call?
It's going to be on the video. If you'd like to have the deck or pieces of it, just shoot me an email and we can talk about what we can share and what.
Cool, will do. Thank you.
My pleasure.
Rick, thanks. That actually segues into one of my points. This is recorded. So everybody on this call, if you come across somebody who you think may be interested in the topic, maybe mention that to them and refer them to the website or just to Paul directly. just to close things out, for those of you on the call today, we have a different kind of event coming up that hopefully will be, I want to say, somewhat of a return to a sense of normalcy, just a pure networking event next Wednesday, September 2nd. Just getting people together to talk and chat. You know, we found that the breakout rooms after some of these events have been very nice, and give people a chance to connect in a not one-on-one, but maybe just 4 people in a chat room, and then mixing it up a little bit. So we hope all of you can join us, and regardless of whether you can, please spread the word, because it'll be great to talk to a lot of people, even if we still can't do things in person. And that's it from my perspective. Paula, any closing remarks from you?
No, I'd be happy to help provide some information, and even if it's not related to us engaging and working with some folks, we can help spread the word and help support the membership. Be happy to offer whatever insights we can.
Okay, great. Paul, thanks again, and everybody else, thank you for tuning in today. Have a great weekend.
Thanks, everyone.